Hello everyone, Assalamu alaikum. My name is Dr. Anas Ahmed. I'm an attending physician at Tufts Medical Center in Boston in the USA. I work in the division of pulmonary critical care and sleep medicine. I deal with advanced interventional procedures dealing with pulmonary medicine. And I would like to thank Dr. Khwaja Azim and Dr. Talat Wasim for inviting me to give this talk at the Shalamar Surgical Symposium this year. I'd also like to thank Dr. Shoaib Nabi, who's been a great mentor in my career and helping me get to this point in my career. This talk is titled Small Bore Tube Thoracostomy, Does Size Matter? And this terminology, tube thoracostomy, is interchangeable. So throughout the talk, I might say chest tube, I might say pleural catheter, I might even say pigtail chest tube or pigtail pleural catheter. These are all interchangeable terminologies in my head. Anything that you use in a cylindrical tube fashion to get into the chest cavity, either to remove fluid or air, you can call it a chest tube, the procedure tube thoracostomy. The picture that I'm showing on my first slide here is a small bore pigtail catheter, and as you can see, the end of the catheter shows a shape that is like the pigtail. So that's where the terminology comes from. With any talk, the first thing that you need to define are what are the objectives of this talk, and I have four. The first is looking at indications of this procedure of tube thoracostomy. The second is the importance of thoracic ultrasound, and this might be a little uncharted territory for a lot of people listening to this, but the importance of using ultrasound in this setting is, I'll highlight that, it's very important. The third objective is complications that you see with the procedure. And the last is differences between large bore and small bore chest tubes, and where to use one or the other and what the thinking behind that is. So, I'm going to start off with a case. This is someone I took care of in the ICU. It's a 68-year-old gentleman who has a history of COPD with recurrent exacerbations. He presented with acute hypoxic and hypercarbic respiratory failure and required intubation, was put on the ventilator. He was treated with antibiotics and steroids over the next few days, was getting better, had a clinical improvement, and he was extubated and placed on BiPAP afterwards. During the course of the day, about 6 hours later, he had an acute decompensation. He had, tachypnea, his SATs dropped, he was hypoxic, and he was, intubated again, and the following x-ray was obtained. So if you look at this x-ray, I'm just going to point out the area that, it's quite clear what the abnormality is. The lung is just collapsed here near the left heart border, and you can see there's a large pneumothorax. And, and you can see that, there's an endotracheal tube in place, but with the acute decompensation, he was reintubated, but we noticed this big pneumothorax. So one of the things that we did right away afterwards, which we could have done, in the acute setting, was grab the ultrasound. We have an ultrasound in each of our ICUs, and I can go into the details of how to do thoracic ultrasonography, but I think that'll be beyond the scope of this talk. But I'm going to show you some images and try to walk you through what to expect. So this is a picture taken, a video taken with a phased array or a vascular probe ultrasound. And I'm going to play this again. And before I play it, this structure here is a rib. This structure here is the rib next to that. And this is the soft tissue. The skin is up here. Down here is the pleural line, and what we're looking at in the video is the sliding of the pleura. The visceral and parietal pleura are sliding, and you see this normally because if there is no pneumothorax, there is no air between the two pleural linings, then you can see this clearly. So let me play it again. You can see this subtle sliding of, which is normal. This is normal lung sliding. And this you can do in various places on the body in an acute setting that allows you to, evaluate for not only pneumothorax, but, a lot of other abnormalities. But in this case, what I'm trying to show is how to look for pneumothorax. The second, this is just a picture, you're looking at the same area, but if you see that pleural line and there's no sliding, then you have to be concerned about a pneumothorax. So the absent lung sliding is one of the things that, puts that thought into your head that you might be dealing with a pneumothorax. So, the role of ultrasound in pneumothorax detection in the ICU, there's kind of three things that, that come to mind. The first is, presence of lung sliding pretty much rules out the presence of a pneumothorax. And this is, well studied both in the blunt trauma population as well as, medically critically ill patients in the medical ICU. There are specific protocols that allow you to do this in a systematic way. So there's 2 to 3 areas on the anterior chest wall, the lateral chest wall, and the posterior chest wall that you can quickly do this. And if you see lung sliding, rule out, a pneumothorax, or at least a significant pneumothorax. The second is that ultrasound outperforms chest X-ray for evaluation of pneumothorax in blunt trauma patients. Now, when someone comes in as a trauma patient, you can do an X-ray to try to look for these findings, but an ultrasound can be done as part of your FAST exam, which is, the focus assessment with sonography in trauma. And that, originally was done to look for more for fluid, for bleeding in the pericardium, in the pelvis, around structures in the abdomen. But the extended FAST, the eFAST, also adds chest ultrasound in the trauma patient to look for a pneumothorax within a minute, and then act on it before you send the patient for an X-ray or a CT. Although a CT does better evaluate the patient overall for other traumatic injuries that the ultrasound would not pick up. The third is, if you do not see lung sliding, that does not mean there's a pneumothorax present. So it's not specific enough to rule it out. However, it does give you a clue that this needs to be further elucidated with other tests, or in the right clinical setting may have a higher chance of that being present. Now, other things that you might think that that can cause lung sliding include if they've had previous pleurodesis, pleural adhesions. Sometimes in a large consolidation or severe ARDS, you might not see lung sliding. Or if there's a a phrenic nerve paralysis on that side, if the lung's not moving, you're not going to see lung sliding. So there is a role of ultrasound in the ICU that is very significant. But I think this is one of the acute settings where it's very helpful, both in the trauma patient as well as in the medically critical ill patients. So this is the X-ray that we did after I placed a 14 French pigtail catheter. So you can see the catheter right there and the characteristic pigtail end. And you can see partially the lung has started to re-expand. It's not expanded all the way, but it started to get better. So having a small bore pigtail pleural catheter available is very helpful in a setting like this, as opposed to a large bore chest tube. And I'll go over those details in a little bit. But this is the kit that I use. It's a pre-packaged kit that comes with everything that I need to place the tube. You can see there's a stiffener there. There's the catheter itself. There's a scalpel. It comes with different attachments that you can put the tube up to a pleurovac. Even comes with lidocaine, scalpel. So there are different ways this can be put in. Either this particular kit is the tube is placed via the cylinder technique, but a trocar with needle and other ways, with blunt dissection, you can place these catheters. It's just operator dependent and operator preference. But this is the kit that I use, and this is how I place this chest tube. So now, we're going to look at the indications for tube thoracostomy. And, a lot of these are intuitive. The first two are the most common ones that I would think in an acute setting or in a trauma setting that we think of, and that's a pneumothorax or hemothorax. And, urgently placing chest tube for these two things can be life-saving. The other two are more in the post-surgical cardiac surgery, thoracic surgery. You expect, some bleeding or, some fluid that needs to be removed after the procedure, and, a chest tube is placed as a, something that you end the procedure with. As part of a pleurodesis, or as a means of doing pleurodesis, a chest tube might be placed. And the last, which probably encompasses the most common reason for placing a pleural catheter, is a pleural effusion, both for diagnosis and for therapeutic reasons to help alleviate symptoms. So the most two most common reasons are if you have infection in the setting of a complicated parapneumatic effusion, or an empyema, a true infection of the pleural space. And the second is malignant pleural effusion, to diagnose it and to drain it to help symptoms. And then there's a myriad of other reasons a pleural effusion might occur in a cardiothorax I put up there, just because it usually is a large effusion that occurs and needs drainage. But these are few of the indications to place a chest tube. I've placed chest tubes in patients based on where I am. So if I'm in the clinic, I'm in the ICU, I'm in the emergency room, I'm on the regular ward, and there are different patient positions that you can choose based on your own comfort level, the patient's comfort level, whether they're intubated and on a vent, whether you're trying to get to a certain position because the fluid is lower in the chest or posteriorly located. And this is decided after I've done chest ultrasound to look at where the fluid is, where's the best pocket. And I'll show you some pictures in just a moment to look at that better. But this, where the patient is semi-reclined with the hand behind his head, is a common position when the patient is lying down. One is in a lateral decubitus position. If you're trying to get to the lateral or posterior chest in let's say in the ICU, and if you're in the office and in the clinic and want to drain some fluid, this is the most common position, with sitting up, leaning over a table, with usually a pillow or some padding on a table So the patient is comfortable, kind of just resting and dozing, and you're working on their posterior chest. Usually when I do this with some trainees, if they're doing the procedure, I'm usually just standing on the opposite side, just talking to the patient, making sure they're comfortable, and kind of taking their attention away from the procedure that's going on, because you can do this procedure with the patient not having any pain or very minimal pain or discomfort. So this is, a picture of an ultrasound image looking at pleural fluid. So this area right here that I'm pointing out is the fluid in question. It's black. You can see the diaphragm here. That's the white line, and this is the liver, which is below the diaphragm in the abdominal cavity. And kind of far out, you can see that you might sometimes see the edge of the lung right there. Up here is where the probe is, where the skin is. So this, once I've placed the probe on the patient, I can see that this is a good spot for me to introduce my needle to gain access to the pleural fluid. So once I've found this spot, I usually mark it, and there are different ways of marking that area, but once it's marked, I know what the target is. And there's different ways of looking at the fluid and kind of getting an idea, what are we dealing with. So this, you see, just a black picture, really not much, very simple appearing fluid. In the second picture, again, just to orient yourself, the probe's up here, the skin's up here. This is the diaphragm, that white line. This is the spleen in this case. And you can see the edge of the lung right here. So this is the lung. And you can see this septation actually, that is connecting the lung to the diaphragm. But even more than that, you can see some of this haziness, haziness even down here, which is just some sediment. So maybe some of this fluid is not just simple appearing, that there might be some sediment to it. There might be, this might give you some clue that this is not a simple pleural effusion. This might be a complicated pleural effusion. When we find septation, and I'll show you some more in a second, the correct kind of ultrasound terminology is not complicated pleural effusion, it's complex. Again, this is just, some of this is semantics, but I think, calling this a complicated pleural effusion without knowing the pleural fluid analysis might be a little premature. In this case, again, skin up here, you can see all this septation, and this is quite clearly a complicated pleural space, a complex image right here. And once this was sampled, you could make that diagnosis of likely a complicated pleural effusion, parapneumatic effusion, or an empyema. And sometimes even malignant pleural effusions can have septation like this. This, again, similar kind of picture, dense kind of septation, and once you can get to the pleural fluid, you can drain it and then diagnose, manage accordingly. So the images do help decide a placement of the catheter, but also gives you certain ideas of what we're dealing with. So, these are, any talk that I do, I almost always bring up guidelines. And in this case, these are guidelines from over 10 years ago now. So they are dated, but I think going back to guidelines gives you some kind of platform to then, decide, well, there's more data out there now, how do we change and build on those guidelines? But even 10 years ago, the British Thoracic Society Pleural Disease Guideline on Pleural Procedures and Thoracic Ultrasound said that, if you're going to perform pleural aspiration, or a chest tube, a recent chest radiograph should be available. So that's I think a given in any case, to know that you have evidence of fluid. But they make a strong recommendation that thoracic ultrasound should be performed and used as a guidance to help with all pleural procedures. And there's a reason for that. And I'll mention that again in a second. There are complications with any procedure that you deal with, and the complications differ between whether you're dealing with a small bore chest tube or a large bore chest tube. In general, when you look at complications, pain, because once you place the tube, there is something sticking out, the back or the side of the patient, and then it's going to cause them pain. A lot of times it's discomfort and not true pain, but there is an element of that. The bigger the tube or the smaller the tube, that does play a difference, or play a role in how much pain there is. Anytime you're putting a needle into a body cavity or a patient, you're going to encounter bleeding, and the ways of minimizing the risk of bleeding, patient factors, medications that are on, choosing areas, procedurally, how you do it, makes a difference in that bleeding. You can lead to intrapleural infections with placement of a chest tube. Again, this is not that common. It's rare, but if it's not handled correctly, the post placement care isn't correct, then the chances of infection are high or present. You can get wound infection if again the post-procedural care isn't good and the tube is left for a long period of time. This is more common when tunneled or indwelling pleural catheters are placed for recurrent infusions, recurrent malignant infusions. You can have drain-related visceral injury, so an intraparenchymal tube placement or intra-abdominal tube placement. That ultrasound helps decrease the chances of that, because you know where your target is and you've visualized it before. And then drain blockage. And this is something that comes into play when we talk about small bore chest tube. So if the diameter of the tube is smaller, then if there's any debris or any clots or anything like that, then the drain can be blocked with that, or the tube itself can be kinked and cause blockage. The last is failure of the procedure. You might try to place the tube and you're just unable to. I always put that as one of the things that can be part of the complications, because you start out by doing the procedure, your aim is to get this tube in, you might not be able to. A variety of different reasons can lead to that, but that's one of the things that I always mention to the patient as a complication that can occur. This looks at rates of complications based on who is doing the procedure, and also whether ultrasound was used or not. So if you look at these two columns, the operator column shows, there's two where it shows either a radiologist in training or a physician in training, a senior physician like an attending physician, an attending radiologist. And then up here there's three which show whether they use ultrasound, and the last either a physician in training without ultrasound or a senior physician without ultrasound use. And if you look at the frequency of complications, specifically pneumothorax, or if they needed a chest tube afterwards, this is just looking at pleural aspiration, or if you had a procedure failure, just again, this is not a randomized trial, but just looking at the numbers, the percentage of frequency of these complications is higher in the cases, ultrasound was not used. So a frequency of post-procedure pneumothorax up to 15%. It was decreased to about 5-6% if it was not a physician in training, a senior physician. But again, if you use ultrasound, then the risk of or frequency of a pneumothorax is low. In the same case with whether a drain was required afterwards, it increases if ultrasound wasn't used. The same with procedure failure. So I think this slide looks at both the importance of being trained in the procedure, but also the use of ultrasound in helping with the procedure. And I think that's one of the things that training with ultrasound is so important nowadays. This table looks at complications in small drains, so less than 16 French. And the one thing I want you to look at, in general, injury, malposition, or empyema, the frequency is low, but the frequency of drain blockage is high. So there's certain ways you can prevent that, certain things that you can do, both in choosing who you're placing the tube in, but also how you take care of it afterwards. So in all my patients that I place a chest tube, I usually have the tube flushed with just saline at least twice a day. So that way anything within the tube doesn't have time to kind of just stay there and block the tube. And you can flush it both into the chest cavity with about 10 cc's of saline and about 20 cc's into the drainage bag or the pleurovac. The same kind of table for large bore drains, or drains that are greater than 20 French. The drain blockage is lower, but the frequency of malposition might be a little higher. This doesn't look at the frequency of pain or other things that a large bore drain might have more of, but at least a large bore drain not cared for afterwards can still lead to drain blockage. So it's not something the size of the tubing fixes. I think there's something more to it than just that. So this brings me to talking about small and large bore chest tubes and the difference in between them, in how you think on the choice of placing one versus the other. The easiest thing to think about when you're doing this is, what are you trained to put in? So if you're only comfortable in placing a large bore chest tube with blunt dissection, that is the best choice. However, having that extra know-how or procedural capability of placing different sizes or different ways of putting in a chest tube allows you to then make the best decision for the patient in a case-by-case basis. So, when we think about large bore or small bore, the difference is basically, if it's less than 20 French, then it's considered small bore. If it's greater than 20 French, it's considered large bore. Now, this distinction is really not well established in literature or in the research world. So if you look at different studies looking at these two sizes, you'll see a lot of variance in what's defined as large or small bore. But I think in most people's head, anything above 20 French is likely considered a large bore chest tube. There's many studies that have looked at what's the difference between the two. This one experimental study that was published in the Asian Cardiovascular Thoracic Annals a few years ago now looked both in vivo and in vitro, looking at 19 French and 28 French tubes. And they showed that the larger tube had an in vitro capacity that was 9 times higher than the smaller tube when it comes to drainage. But in vivo, both tubes had the same drainage capability over time. So that also plays into how well you care for the tube and allow it to not get blocked, especially in the smaller tubes. So even though, if you think in terms of physics and cylinders, and a large tube makes obvious sense that it would be better in terms of drainage, but when you actually pragmatically look at the drainage inside the pleural cavity, there's not much difference in terms of drainage. And this slide, it's a busy slide, but it looks at 6 studies, and I'll give the references for them in the next slide, looking at small and large bore chest tubes, and they reach certain conclusions. And again, you can see, I already mentioned this, but the difference between the small and large designation. So the small in some studies was as small as 14, as small as 10 and 12, but in certain studies up to even 28, 32. But for the most part, if you look at the first few studies here, there's comparable drainage rates, and so this is something I already mentioned, between smaller and larger bore chest tubes. So there's not a significant difference in many studies that has looked at the amount of drainage you get and failure of drainage between the two. The next 3 studies kind of looked at what's the benefit of a small bore catheter, and the biggest thing that they found was patient comfort. So the comfort of a smaller tube, and there was less pain associated with it, is a kind of a major plus point that you can see when these studies were done. And there is some ease of placement based on you can find the ideal spot to put it in based on your chest ultrasound. If you have time, these are the different studies that I just mentioned in the other table. But there's multiple literature points out there now looking at the 2 kind of categories. So when you look at, if I were to list the advantages of a small versus a large, so this is just looking at the picture of a patient who had a small bore chest tube placed. This is placed in the back, where the fluid was most easily accessed. And as you can see in this case, when the patient's lying down, there's a bandage that's been placed, so it's kept in place, and it's just brought to the front so it can be drained down into a pleural vac or a drainage bag afterwards. And it's fairly comfortable because the patient can lie on it, and it's not something that is, of course there is some discomfort, but it's not a huge tube, a huge hose-like tube that is sticking out their back. So if you were to list the advantages, there is data that shows there's less pain with smaller bore chest tubes, and it's more comfortable for the patient because they can, lie, if it's in their back, that they can lie on it. It allows for some flexibility in the tubing. There's some easier mobility because if it's placed and it's not a big tube, then they're sometimes easier to move around for the patient and be able to get onto their feet and do some physical therapy and things like that. This I think is probably the most kind of important point, because it allows you to then go where the fluid is with the help of a thoracic ultrasound. So if it's in the back or in the front or up, kind of in an area that you would normally not put a tube in, outside of the triangle of safety, with the thoracic ultrasound in a smaller tube, there is overall less risk of any complications. And this is definitely a big advantage of a smaller bore chest tube. And for the most part, there is a similar efficacy, so you're not losing any of the benefits that you get, the reason why you place the tube. And I think the big exception of this is in the presence of a hemothorax, both in allowing adequate drainage without any blockage, but also in the setting of an acute trauma where the fastest way you could place this with blood dissection and a big chest tube to take care of the acute setting. I think those are the two instances where a large bore chest tube is the first thing that you think of. There are some disadvantages, though. If you take good care of the chest tube, like I mentioned, with regular flushing with saline, these can be minimized. But some of these chest tubes can get kinked, and if they're kinked, then any fluid passage or any drainage will be blocked, and that can happen right at the insertion site, can happen sometimes within the chest, and lead to kind of failure of drainage. The other is if there is thick fluid and just gets blocked, and then you either need to flush. This can be in the setting of infected pleural space and empyema with a lot of pus. And in those cases, there's now a lot of data and recommendations looking at TPA and DNAs to help with fluid drainage and success with small bore chest tubes. And the last is, again, very rare and a little more common with indwelling pleural catheters is tube rupture. And that can, if that were to happen, then sometimes there might be part of the tube that's either sticking out of the patient or even left within the pleural cavity, and that needs surgical extraction. But the cases of this are very rare, and with near and near tubes coming out in the market with materials that it's very hard for rupture to occur if handled in the right way. That kind of brings me to the end of the talk, and I'm going to leave you with a few conclusions. The first being, small bore chest tubes, they have, similar efficacy for most pleural diseases, for most cases. The exception of, being hemothoraces and acute trauma with acute pneumothorax. That you may place a large bore chest tube as part of that initial management. But if you have some time to think and plan your procedure, then I think a smaller bore chest tube should be the procedure of choice. The small bore tubes are less painful, and they're more comfortable for the patient, so you're not losing any of that benefit, but you're also gaining some of that. That there's less pain. The patient's able to be more, walk around, be more mobile. And thoracic ultrasound is strongly recommended for any pleural procedure, not only for the success of it. It allows you to get to the fluid pocket with very good, access, low risk, and gives you a lot of confidence when you're placing a tube that you're getting to the right spot. The other thing thoracic ultrasound helps in is in pneumothorax detection and just evaluation of pneumothorax in an acute settings, especially the trauma patient. And the final decision, I think, is made on a case-by-case basis. The body habitus that you're dealing with the patient, the anticipated course, the operator and institutional preference. If you're not trained in placing a tube a certain way, then I think the way you're trained to do it is the best way to do it. It will lead to the best care for the patient at that time. But I think having more training in placing smaller tubes will lead to just having more choices and better management choices in certain cases. So that brings me to the end of my talk. Thank you for listening. I would like to hope the next time I'm giving a talk, I can do that in person and not virtually. And hopefully, once this pandemic comes to an end, we can do that. So thank you again. Before I go, I actually forgot to mention this last slide. This shows, the various institutions that I was lucky enough to train at and gain, access to great physicians, great mentors. So in the bottom right, that is the Services Institute of Medical Sciences, where I went to medical school. And then up here is the Tufts Medical Center in Boston, where I'm currently working, where I did my training in pulmonary medicine and critical care. And then this on the left is the Beth Israel Deaconess Medical Center, one of the Harvard Medical School hospitals, where I did my advanced bronchoscopy training. I usually put up these pictures to show the kind of the journey that I've had till now, but it did start back in Pakistan with SIMS. This is what this picture shows, and thank you again. And like I said, I hope to see everyone in person soon. Thank you. Bye.